morning to everyone. Yes, so my presentation is on enabling environments, lasting impact, supporting young key populations in HIV treatment. I have nothing to declare, and I will start by saying that as at last year, 2024, we had half of all new HIV infections occurring in sub-Saharan Africa. And out of these, a third of these new infections occurred among the youth, those aged 15 to 24. Though we've seen a decline in new HIV infections in the general population, we've seen data over the years from 2010 till date that there's been a persistent increase in infections, in new HIV infections among the key populations. And this ranges from 19% in people who inject drugs all the way to 95% among gay men and other men who have sex with men. Why are we seeing this? It's because we still have persisting gaps in treatment and in coverage. Now, the enabling environment, what is it? It's a space, it's a varied space. It may be a legal space, it may be a social space, or a clinical or legal space that minimizes risk and supports and protects health, rights, and well-being of the people they seek to protect. And as you can see, there are key elements of these enabling environments. What I want us to note here is that every key element listed here is not part of the biomedical intervention. And therefore, it is key for us to understand that to be able to achieve the goals that we seek in this fight against HIV/AIDS, we need a deeper collaboration between the social scientists and the biomedical scientists. If this is not looked at, we would not get to achieve our aims. I think the presenter before me has just shown that the biomedical scientists are still working and are giving us lenacapavir. Every day there is a new innovation coming. But then, these innovations are for individuals. And every human being is a social being. And once you're a social being, you have social factors affecting you. And therefore, these need to be considered before we can be able to achieve our aim. So just to look at our treatment cascade, this, I think many of us are aware of because we are implementers in our own areas. But what I want us to note is that this treatment cascade cannot happen and achieve our targets if the environment is not enabling. We are looking at the human rights, we are looking at gender equity, and we are looking at zero tolerance for stigma and discrimination. Again, if you look at the treatment cascade, right from diagnosis, when you are diagnosed to be positive, all the way through to linkage to care, to start of ARVs, and also to your monitoring, you realize that under each of them, there are structural barriers, there are psychosocial issues, which needs to be addressed. And these, I think, for some of the implementers, or for most implementers, we lose track. And because once we come up with our own plans to roll out, we tend not to look at these things very carefully, and therefore we run into challenges. Now, depending on the kind of model that you implement, it comes with its own challenges. Now, we also come to the issue of evidence for the treatment cascade. When it comes to the key population, the young key population, we have issues with data. Data is unavailable. And the reason is simple. Most surveys and programs do not disaggregate data to the levels. You usually see them aggregated 15 to 49 years. And even for young key populations, it's very difficult to get a cascade data. The other reason also is that most of these young ones, when they do find themselves in treatment, they are afraid to identify themselves as part of a population. And so they say, I'm part of the normal population. And so that data is part of the general population. And that's the challenges we are having. But if you look at what literature is showing us, we have gaps. In fact, in the cascade from the Zimbabwe Biobehavioral Survey, you can see that we have almost 21% of our young people who are still not suppressed. And then for the female sex workers, you'd realize that we have, although we have 85% being put on ART, our suppression rate is only 58%. Again, if you look at the youth in general, from the Chiesa community model, you would find out that the linkage rate, it's only 70%, which means 30% of the people are out there. Now, again, if you look at the attrition rate for young persons put on antiretroviral therapy, at 6 months, it's 40%. And these are challenges. These are issues. Why are there issues? Because our models of care need to be really looked at. There are issues with our models of care, whether it is in the community, whether it's in the facility, whether it's a combination of both. We really need to look at designing a good model of care, and that starts with co-planning and co-designing with the young key population. I think many have said from yesterday, and today I've heard it again here, that you can do nothing for us without us. Please let us not implement or have our plans written down. And then we call them to join committees as advisory groups. And then we tell them, we want to do this. What do you think? No, but before we put down the plans, let's call them to the table and say, we want to write a grant for this. How should we do it? If you are tested positive, and that is where I think we should include those that are positive, already positive. If we are asking you to go to this clinic, what are the challenges? If we want to serve you with your drugs in your home, what do you expect? And so we need to look at this because the model of care that we implement, it can directly facilitate or inhibit the care for our young key populations. And this, I think, is something key that we need to note. The challenges to treatment have been well documented. I will not waste time going through all, but what I want us to know is the triple vulnerability that the young key populations undergo. The first one is because of their age. They are young. Second, it's because of the positivity status. And the third one is because of the key population community that they belong to. And therefore, these challenges would really need to be looked at, depending on the population of interest. Facilitators too have been well documented for treatment. And these have been done through pilots, through community model implementations. And I think what has gained a lot of traction has been the differentiated service delivery model, has also been the integration of services. And recently, for the past few years, we are now seeing the use of technology or digital tools as well. But let's look at some of the best practices. And I think it has ranged from implementing DSDs, using the drop-in centers, the one-stop shops, also doing the home ART delivery. The literature shows that even in Botswana here, there are some private courier services as well. What has gained traction a lot is the use of the community health workers in most of the programs that are being implemented. And then we also have the point of ART distribution, which is happening also in Burundi and DR Congo. And these have been shown to increase uptake of ARVs, improve retention and care, and increase in viral load testing. Now, the other peers that have also been shown to work well are the youth-friendly and peer models. And again, I think yesterday we heard about the Svandiri program. And also there is the Red Carpet program, which was implemented in Kenya. And then we also have the adolescent-friendly health service training and implementation, which also showed that it significantly lowered loss to follow-up rate among the young key population. The Red Carpet program also indicated was mainly looking at retention and care and showed that retention had increased from 66% to 90% within 3 months, and also from 54% to 98% within 6 months, which was good for us. So these models are working, or the models work. But what happens when the program ends? That is the problem, because the models show that things work. In the real world situation, we have challenges. And what are the challenges? It's because of sustainability. And how do we look at this? We need to streamline youth and HIV activities in our countries. Now, I think from 2020, when the COVID came, funding started decreasing. And I think from this year, it's been very evident that it's decreased further. Can we start streaming our youth and HIV services? Can countries have established youth and HIV service directories where any NGO, anyone who wants to work in a certain context, can easily have access to see who is doing what in what district, and so that we can be able to pool our resources together, because that's one of the major challenges, logistics. So we can also improve data for HIV care, especially for our young key populations. We need a deeper collaboration between community-based actors and facilities. Please, people are doing a lot in the community, and I respect them for that. What happens is, if we need to connect to the facility where the biomedical intervention occurs, most of the times we go to talk to one nurse, one doctor, and then we say they will come and see you. Or can you come to see our patients at the DIC? Can you come? Yes, they will come. But when the program ends, what happens? The sustainability of it is a problem. Facilities also see it as if they are just helping in projects. They don't see it as being co-owners, because they were never involved in the planning, but they were being told that we want you to do this for us. And so we need to do better in terms of co-creation and co-linkages with facilities, so that supervision and then good feedback mechanism and monitoring gets better. For the co-planning, I've talked about it. One of the key issues we have when it comes to key population, the young key population, and I think yesterday they talked about a pregnant one and the issues they had with funding, because you have to live as an adult once you are pregnant. And the whole issue is about funding. It's about money. Why don't we come up to say that if you have to implement HIV KP programming, you need to incorporate a socio-economic empowerment program? Because at the end of the day, we tend to empower them with livelihood programs, vocational trainings, so that, yes, in the beginning, we can start with our cash transfers. But as time goes on, they build their capacity and they take responsibility for themselves, so that we can sustain the things that we begin with. For stigma reduction, please, it's good we are training healthcare workers, but I think we should start including this training in the healthcare training centers. We shouldn't wait till they become healthcare workers. We have a very high turnover rate of healthcare workers at site. And so when you train people today, tomorrow they are gone. But if we are able to include it in their training, and we are training them by the time they come out of their institutions, they are KP competent in terms of providing services for KPs. And they are also able to understand what a youth-friendly service is. Whether we move them around in months, we still are assured that people still understand what it means to provide such services. Now, the mental health support, it should start right from the time of diagnosis, because that is where the issues come up. Why am I positive? What will happen to me now? Right from there. If you do not tackle that and you start to talk about linkages may start by to not be sustainable. And then they now become the source of infections again in the community. And then we need to improve our program collection tools to try to include the variables that will collect data on the young key population, so that we can plan for them better. So what has to be done? For policymakers, we need to reform our restrictive laws. And yesterday we heard Rwanda is reducing their permission age to 15 years, and that was very warming, and we asked that other countries follow suit. But for the Ministry of Health agencies, we should include in our pre-service and in-service training stigma reduction and YKP competent service provision. For healthcare providers, once you have been trained, the onus lies upon us to deliver youth-friendly, stigma-free, and KP-competent care. And for donors and for partners, please, let's invest in youth-led initiatives. We do not have enough funds. But if we do have the funds, let's ask the youth that this is what we are planning to do. Can you lead it for us? And then let's support them. For CSOs, CBOs, and community actors, we need to provide targeted and tailored interventions based on the people that we are seeing, and we must be the bridge between the facilities and the communities. And for communities, we ask that they support open dialogue. I want to end here by saying that when environments enable, the youth will thrive, and when the youth thrive, HIV loses ground. Thank you very much.